So thank you for joining us for this session, especially our panelists who I'll introduce shortly. This is part of the VIR match series. This is the resident panel, and we will be discussing choosing the right VIR program for you, as well as preparing for a 100% VIR career. I'll be the host today. My name is Ryan Nolan. I'm a second year medical student at the University of Nevada, Reno, and I'm the WCVIS mentorship chair. So I want to give a brief overview of the West Coast Vascular and Interventional Society. The mission of the WCVIS is to develop a trainee section to educate, recruit, and connect those passionate about pursuing a 100% endovascular and interventional surgical career with comprehensive and longitudinal clinical care. The direction of VIR as a specialty will be defined by those who will not compromise in providing the best possible care to their patients. We have various sections for all levels of trainees, ranging from pre-medical all the way to resident and early career. We do have an abundance of ongoing projects, and we'll talk about some ways to get involved. One of which is a spreadsheet for all VIR programs that give information about, for example, PAD experience, neuroventral training, etc., as well as multiple series like the How to Crush Your Sub-I series, which we'll have one in the future, near future. We also have the Acute Care series, the WCVS Match series, which this is a part of, the Unite plus WCVS series collaboration, as well as the Landmark Trial series. We also have educational resource projects that are ongoing, such as procedure guides for Spanish-speaking patients. And we have mentorship initiatives, which, like, for example, the Mentor Match, which we will be implementing in the near future, as well as resident office hours. We also have upcoming podcasts on 100% VIR practices and much, much more. If you're interested in getting involved and staying updated, many of you have already, but please join the WCVS trainee section. You could sign up using that link, the QR code, whatever's more convenient. Also follow us on social media, the WCVS Society on Twitter, Instagram, TikTok, and YouTube. Also, please check out our website, WCVIS. That's updated very frequently, and it's a great resource. So without further ado, I'd like to introduce our panelists. Our first is Dr. Webster. She is a fifth-year resident. She completed her surgical internship at Mount Sinai, and she's also completing her VIR residency there. So welcome, Dr. Webster. Thank you for joining us. I'd also like to welcome Dr. Desai. He is a third-year resident at Jefferson Einstein Philadelphia Hospital, and he also completed his surgical internship there. I'd also like to welcome Dr. Jonas Kruse. He is a second-year resident who's attending UCLA for residency and who also completed his surgical internship there. And I'd also like to introduce Dr. Loudon, who also made it here. He's on VIR call, so thank you so much. He's a fifth-year resident at the University of Michigan, and he also completed his surgical intern year there. And I think we could start with some introductions. And I think maybe one of the best ways to introduce yourselves, you could just tell us a little bit about yourself, but also what you have as an ideal, or what you see yourself ideally practicing VIR in the future, what ideal practice is for you after residency. So if you don't mind, Dr. Desai, we can start with you.
Yeah, hey everyone. Yeah, my name's Sagar. I think maybe the slide's not updated. I'm a PGY 5 at Einstein. So getting close to gonna be incoming chief next year, and then getting close to the career search soon. So in terms of what I was looking for a training program when I was in MS3, MS4, knew I wanted to do IR. I was between surgery and IR, and I did a couple of weight rotations, which I think really is because there's so much heterogeneity in terms of like how programs are set up. So I did one on the West Coast with Dr. V, and then two on the East Coast, and I saw early on there's kind of some differences in terms of how often people go to clinic. The program I'm at now, where I did in a way, did at least one half day a week, which I thought was really nice. And when you're in clinic, it's not shadowing. You're expected to see patients yourself, write the notes, coordinate follow up, check in, and have longitude of care. So if the patient's getting a procedure done, you get to do that even as a PGY 2 or 3. So I thought that was important. And then in terms of what your center does, so I wanted to go somewhere that ideally had like a level 1 trauma center. IR did PE, DVT stuff. We had transplant, which is a bonus, liver and kidney transplant. And then we do some neuro stuff, and also do, all the fistula work and some like interventional oncology Y90 stuff. So I think having a good hand in a pot for everything. It's hard to come across a program that does PAD, but I think the rest are really attainable goals for a strong IR program. So something you should kind of um, keep in mind. And then also, I think it's kind of cliche, but like the people, the attendings, make sure the attendings have been there. The ones who are like key leadership positions have been there for at least, 5 years or so, or have like you can see they have motivation to stay. Because when you go to rotate somewhere, interview somewhere, you're not going to join until 2 years later. And unfortunately, I've seen people, match somewhere and then within an 18 or 24-month period, vastly different program when they start, as an incoming PGY too. So just look for a place who has had a kind of stable longitudinal, for the last 5 years, everyone's kind of stayed the same and you think they're going to stay the same. Stuff changes. Like my hospital was bought by Jefferson kind of just about 2 years ago. So that was a change, and but don't freak out about stuff like that. It's kind of out of your control. So kind of keep it in mind, but I don't think that should be a big priority. And then I don't want to take up too much time. I guess in terms of job search, I mean, I started looking about probably like 3 months ago, so like putting out feelers in terms of the geographic area I want to stay in the Northeast, or potentially SoCal. But I want to do 100% IR, and I want to make sure I kind of keep the kind of service lines that I was trained in, kind of keep those up. And in terms of practice itself, I understand, if you join like an academic place that has more than maybe 10 IRs or 8 IRs, you're expected to kind of subspecialize, but I want to make sure that within the first 3 years, I'm not pushed into kind of just one niche. I want to be able to have my hand in everything. And maybe as an attending, I feel differently about certain disease processes in different clinics than I did, as a as a trainee. So I kind of want to keep, those options open. And I've spoken to a few people like chairs, and I've told them, like within the first 3 years, I want to have the option to kind of do everything. And then after that, maybe if I have to pick a niche, that's understandable. And yeah, I mean, if there is some, DR options electively, I think that's fine. But I personally don't want to be somewhere where I'm kind of in charge of a list, certain days of the week. I feel like that might take away, especially in the beginning, in terms of me developing my own patient panel and kind of meeting with other subspecialties and like developing that rapport. I feel like every day kind of matters. And if you're taking one day out of the week, that's 20% less time than, other places. And then I guess the last thing I want to touch on is just same thing, as a training program, like places that I go to, I want to make sure they have like clinic in place and they have maybe some APPs to help offload some of the work, because there's a lot of stuff coming on at once, as an attending. So definitely want to see like that in place, and options to grow other service lines that the practice might not have. So, if they don't have like vertebral augmentation, but I want to like bring that up. I want to make sure that leadership is open to, me kind of after the first 2 years or so, kind of just taking on a project for my own and kind of branching out and trying to network that way. So.
Thanks so much. And I think you made a lot of great points, especially when you discussed how, taking time to go through a list and, read imaging will take away from your ability to build your practice, your clinical practice outside of residency. So that's a very important point. Dr. Webster, would you like to go next?
Sure. Hi, everyone. I'm Lindsay. I'm currently a PGY3 at Mount Sinai. I also am the chair of the RFS section. So if you have any questions about getting involved, please reach out. We've done a lot of restructuring and things are kind of moving around, but you're going to start seeing stuff from us very soon. Wow, Sagar, like those points, so many highlights there. I just have to say, like, agree, ditto. I also want to do 100% IR, and I can't wait for us to like dive further into this conversation. I feel like we have a lot of like-minded folks around here.
Yes, thank you, Lindsay. Dr. Kruse?
Hey, thanks for having me. I'm going to echo both what Lindsay and Sagar said, that just a lot of really high points. Can't disagree with any of them. Obviously, also 100% interested in a clinical IR practice. Currently, I'm leaning more on the academic side of things. Part of my mentorship right now is within being able to kind of find what kind of practice that looks like in the future, but I'm leaning more towards a clinical practice where I can, if I'm interested in something, then build up a data set behind that and maybe answer a few questions. But yeah, right now out on the West Coast, we have a practice where we're both doing the research and we've got our service lines, and really looking forward to this.
Thank you so much. And Dr. Loudon, thanks for making it, by the way. We know you're on VIR call, so. I can anyone hear? I'm not. Yeah, I don't think we could hear you. Sorry.
Okay. Come through okay?
Good.
All right, nice. Yeah, yeah, thanks again for having me. I appreciate I'm really glad to be here. Especially because it means I'm not, running around the hospital like a chicken with my head cut off. But you know. So anyway, as far as what I'm looking for, and what I valued when I was looking at residencies, I really valued a place with a very good culture in addition to being like really clinically strong. I was looking for somewhere that was like very gonna prepare me really well both on the diagnostic side and on the interventional side. And I I think I don't know if my connection got goofy, but hopefully you guys heard that. Anyway, was looking for somewhere where I could really like have a very strong clinical training in IR predominantly. And that was point number one. Point number two was I wanted it to be with people who I um, wanted to be like when I was done with training. You want to find people that you see as potential mentors and who have the kind of empathy and compassion that you yourself would want to see when you're at the end of all this. Because residency is hard and it's 6 years is kind of a long time, and so you want to be at a place with a good culture. And to kind of chime in off of what Sagar said. I think it's ideal to definitely look for a place with some semblance of stability, but um, remain open to the reality that change is just part of life. And, even if you pick a place where you have what appears to be very long-standing clinical faculty, this can all change over the course of 6 years, which again is a very long time. So, because I just think of my own program as an example. I think a couple of years before I got there, there was a whole entirely different set of faculty who all, for one reason or another, left, and the place kind of rebuilt from scratch. But what was an important through line when I was considering it is what is the culture of this institution and is the culture of this department? And so for me, both of those things were extreme positives. And so that's why I kind of gravitated towards this program. Anyway, what I'm looking for in my own practice is anything where I have the opportunity to practice high level, like full spectrum clinical IR. Um, you know, if honestly, if I had like a 100% IR practice that was like more ports and biopsy heavy versus an 80/20 practice where the IR side of my life is like doing more robust, like full spectrum clinical IR, I would for sure take the 80/20 job. So for me, what matters most is like, is the practice clinical, and do you have a clinic? Do you patients, round on your patients? Are you doing clinical IR? This is what I care about.
Thank you. That's a really good point that you made there. And I think that a general theme, and you guys have talked about clinical IR, and that maybe sounds abstract to some students here. So I just kind of wanted to ask, and it obviously changes throughout the years at different institutions, but what does what could a student expect a day in their life to look like in a clinically focused VIR residency program? And I'm
I
just
love this.
yeah.
Yeah, I love this question because it's different with different institutions because IR is practiced really differently across the country. In my institution, every single day people have at least a half day of clinic, and we have a full staff of APPs that help run that outside clinic in addition to a resident on a clinic rotation. Med students will be with us doing cases. They'll usually get a room, and then they follow all the patients that they do procedures on to and through their hospitalization throughout the month. And then a lot of them also like to take a couple days on consults just to see what that's like. And our institution is so large that it's one consult resident for the main hospital, kind of running and staffing the board. So I guess last week I was on consults and I did 45 inpatient consults. We did, of those, I think 18 procedures. So you're getting consulted for a lot more than just like, hey, please do the procedure. I think that's important. If you're getting consulted and you're doing 80 or 90% of the things that you're asked to do, I'm not sure how much clinical practice is there, right? It sounds like the decision's made before you get to that patient. So we're pretty proud of our very busy consult service and the fact that it does try to be truly comprehensive. But it's hard. I think the more I learn about the way different practices are run, the more humbling it is, because there are many, many, many nuances. But the big thing for me that I'm very happy with my residency is that many of the patients that we see in clinic, like we are considered their doctors, and they've been seeing us for like the spectrum of years, like on average.
Yeah, I think that point about consults is really good about if you're seeing like much more consults than you are doing the procedures, it probably means that you're going up to see patients that sometimes like a place where the IM department just thinks, oh, just consult IR and they'll help like figure it out is a good like barometer of like, all right, like you have a complex patient that maybe isn't a surgical candidate or anything could be going on. They just like throw out like a lifeline IR, like and you can review all the imaging, you can go see the patient, let them know. And I think not every place does that. So if you're a med student and you go to kind of do a rotation somewhere and you see that, you're kind of expected to just run up and see patients quite often throughout the day if you're on the consult service is a pretty good sign. And then I don't know how I don't feel too strongly about this, but I think something to think about too is like if your service, if you guys like primary admit patients that like within your IR service, like we do that, and I think that's a really good kind of it's a learning opportunity through training. Like everyone deals with it their intern year, but kind of having that for the next 5 years, even if it's just 23-hour op stuff, I think like that shows that. I think that's a good indicator because if IR practice is willing to do that, they probably are doing everything else that kind of checks the boxes in terms of like clinic and rounding a bunch on patients and seeing consults. So those are two kind of quick points I thought of.
And to be clear, that's hard. So as a resident, if you have inpatient primary patients, like that is extra work you are doing as a resident that other teams that like other programs that don't do that don't experience because a medicine team or a different team is taking care of those patients. But for better or for worse, with that difficulty, there are a lot of learning experiences. It also can help you be a much more competent doctor because if the only time you're thinking holistically about a patient is the first year out of 6, that doesn't really sound like a recipe for success.
And even if it's something you don't want to emulate throughout your like attending career, at least have it during your training so you could do it and you are exposed to it. And then you could decide, down the line if you want to pursue that or not.
Okay, awesome. Does anyone else want to add anything different or maybe special at their institution?
I think we have a pretty similar type of practice where it's just a lot of very complex patients. It's like you know, some sort of tertiary, quaternary, whatever referral center where there's a bazillion million patients admitted at any given time, and every fancy surgical subspecialty with their weird surgery that they did on these patients, and you're getting bombarded with consults from all these people. Um, I believe I have been told that we're the second busiest consult service after infectious disease, which is like they have like 4 different consult teams. So anyway, it's we're getting blasted at a pretty constant rate. So anyway, you want to be somewhere where you do get kind of blasted, but there's mentorship and people who are able to kind of shepherd you through that and help you kind of like see the bigger picture. You know, I think there's a balance. Like you don't want to be somewhere where people are holding your hand the whole time, and you want to have the autonomy and independence, but um, at the same time, it's nice when once in a while you go with an attending and you see how they what is their bedside manner like? How do they, consent a patient to this complex procedure? You know, how do they talk through it? How do they approach it? How do they educate? I think these things are all like really, really valuable to learn from. And yeah, I find myself often saying things to my patients that I've heard my attendings say, just very kind of uh, yeah, I don't know. I think we're all kind of molded by our mentors. That's what I would say about that.
Great, thank you. And we're talking a lot about what clinical VIR looks like, but during the DR heavy years, what type of clinical experience or VIR exposure do you get during those years so that you don't lose your clinical skills?
I
We
think,
get,
oh, sorry. Uh, I didn't mean
yeah,
to.
go first. Go first.
Okay, all right, cool. I think it's pretty darn rare, looking across the full gamut of IR programs that are out there, to find a place that will meaningfully involve you in clinical IR across all the years of your diagnostic training. So what does that mean for you? If you match at one of these programs, which is quite possible, have to be responsible for your own involvement during these years. So stock the board, pay attention to what's going on with these patients, look at the images. How did they manage this? All these things are like important practices that you should have for your own self. For any sort of actionable findings that you find on a scan, follow up and see what happened to that patient. Check check their flow sheets to see, are they on pressors, all these kinds of things, like, and start to kind of hone your skills as somebody who can really glean um, the most important key pertinent information about what is happening to a patient from the chart. And this is going to pay dividends when you step into that role as an IR. So that's one piece of advice that's across the board, no matter where you land. Um, if you're fortunate enough to match somewhere that has like a longitudinal resident experience with clinic throughout all your diagnostic years, that's a huge, huge plus. Even if you match there, though, that doesn't mean you're going to be good. You have to take responsibility for your own learning. So this is like the overarching theme is like, um, do your best, try to match at like the best place you can find that's going to prepare you the best. But it's at the end of the day, it's going to be on you.
I think that's incredible. Like as a three right now, like thinking about course starting next year, there's just so much to learn. At Sinai, we get 4 months of VIR a year, which I don't know, might be in violation of something. I think most people don't get that. But we get 4 months, and that includes buddy call, which is like 72-hour home call over the weekend for 3 sites. That includes some clinic time, time for conferences. So we get a lot, and we try to chunk them kind of like 1 month at a time. So you kind of have like 4 little spurts or like 2 really big blocks. So you have time to like get better in your skills instead of kind of going on and off every week. But even that, I found myself missing IR. So like this year, I think I get 6 months, and I'm excited. But DR is hard. So like for all this time that we're taking from DR, you do have to not just like teach yourself, but like do studying. Um, because there's a reason that DR residency is so long, and we are condensing it significantly. So I don't know how you guys felt about it, but I'm continually impressed when I go back on my DR call rotations, being like, wow, like this is not easy. I have to like keep learning, keep growing here.
Completely agree.
Yeah, I'll chime in as somebody who just started diagnostic, and my focus when it came through applications was completely ignoring the diagnostic side of things. I'm interested in 100% IR. That's what I was focused on, the quality of that education. The sheer amount of information and the, intellect of the people that are teaching you, that it's an onslaught of information. And the last time, I don't know that I've truly started over, but it's a lot of information. That doesn't mean that there isn't a lot of opportunity to still grow in IR while you're spending, this time in the primary diagnostic years. For us, that means we take our consult call over the weekends. In the beginning, it's pretty infrequent, and it ramps up as you become PGY3, PGY4. It's just a little bit in the beginning, and then I completely agree with Dr. Loudon that it's so much more than just availability. You can have somebody who's very clinical as a mentor and learn nothing clinical if you don't put in the work to then apply yourself to it. And so stocking the board is something that we just get really, comfortable doing. And then I would say having a mentor that's willing to actually break down how they spend their time with their patients. So we have only a handful of attendings that will admit their patients, but those are the ones that if something's going wrong on the table, are the ones who are, getting the calls overnight, and you can just see there's a clinical difference. And so kind of hitching yourself to them, picking their brain when they're available outside of just, what's on the imaging right in front of you has been a huge bonus for us.
Yeah, I feel like you can kind of get lost in the weeds trying to compare each program as you're kind of interviewing or looking at places to like how many months each place does. And I completely agree with Nate. Also, it's how he brought up that as the first point, that it's more about like you as an individual and how you're going to try and learn kind of outside of whatever set system you may be in. Let's say like, worst case, if you don't match VIR, you have to take the ESIR route. Like that's even more of a factor because you're going to have even less scheduled time. So just kind of stocking the board and finding people, like Jonas was saying about who you kind of want to emulate yourself over, and finding times outside of when you're supposed to be in DR to kind of go to IR and pick their brains. I feel like that's the best kind of mentality to have. Don't get lost in the weeds in terms of like how much, months each place has.
Thank you all for your thoughts on that. It sounds like it's very difficult, but you do have to take some initiative and try and do what you can to maintain that experience and gain that exposure. I've one more question here before we move on to talking maybe a little bit more again about your hopes post-residency. But how important do you think it is to gain experience managing critically ill patients as a VIR? And what opportunities in residency are there for you to get exposure to this?
I think the critical care series that you guys have for WCVIS is awesome. I always make it a point to log into that because I gain a lot of information from that. And it kind of like puts ideas in my head, kind of write notes about stuff I want to look into myself afterwards. Because once, you're just looking at one little piece of this whole big puzzle, and then you kind of branch off and can go down rabbit holes and learn more. So I love those lecture series. If people haven't been logging in, I feel like those are great, great evening learning sessions. And then otherwise, I mean, I did like my intern year, I got 2 months of SICU, and then just our PGY 5 year, we have 1 month. We're looking to change that to do more kind of maybe our PGY 3 year, just to do another month. But that's pretty much all we get kind of structured ICU time during training. So outside of that, we kind of have to find other places like the society or others to try and learn. At least that's been my experience.
I think it's a BCG requirement that everyone gets 1 month of ICU for IR. So ours is similar, but our month is in PGY 4 year.
We have a month in intern year and then a month in PGY 4 year as well. Or no, PGY 5 year. And if you're really feeling zesty, you could probably request an elective. Most people, I have not heard of someone doing that, but you certainly can. The reality is you're going to be taking care of a lot of very sick ICU players, like pretty much all the time. IR is always consulted on various ICU people, and you'll have somebody on your list who's in ICU. And so it kind of goes back to what I was saying earlier of like, you just have to get really comfortable being able to kind of quickly and efficiently glean the most important information about a patient's clinical status to know when and how to kind of help them and whether you have something to offer. The I have heard of there's somebody who did like an IR residency and then went on to do a critical care fellowship. I think he's in practice at Brigham, which I think is kind of badass. But yeah, for me personally, I I I personally would not want to do that, but that's just me.
Thank you all for your perspectives on that. I'm transition a little bit again to some post-residency thoughts that you may have. And as medical students, it's a really distant concept, like post-residency. All of us are interested. We want to do 100% clinical VIR. I don't think as students, we all know exactly what that means in reality. So what are some challenges you think there are? And we've already discussed some of them, but what are some challenges that may make it difficult to pursue or achieve 100% clinical VIR practice after residency?
I think Nate's first point about how I said that we all said 100% IR, but there's a big difference in terms of, I talked to one hospital system close to where I live that I was interested in, and I because they have a couple 100% IR guys, and I quickly realized that, they're more so doing the bread and butter stuff and occasionally doing, bigger cases, and I'd much rather work at a very intense private practice that might do more, complex high-end stuff and have to deal with a little DR than a practice like that. So I feel like that's a really good point in terms of 100% IR versus, a little bit of DR. Yeah. And then sorry, what was the other part of your question?
It was just essentially how, or I guess the challenges that you think you have seen so far that students may not necessarily conceptualize that go along with having 100% clinical VIR practice.
I just think job search in general is like the first time, like open market concept for us all. Since we're used to having a structured kind of setting for getting into med school, getting into residency, just having structured interviews, and then you have a day where you kind of figure out where you're going to go, or you get letters in the mail figuring out where you're going to go to med school. So that's very different in terms of the timing. If you want to start early, more than 12 months out and maybe lock yourself down for a place that knows they're looking to hire, 18 or 16 months out. I think, timing is really important and reaching out and like keeping throughout residency, keeping a good network of kind of the geographic area or kind of the practice model you want, and keeping in contact with people at those places is important. Because there's not a big just repository of great 100% IR clinical jobs that's waiting for you to just log into and. So I think that's been kind of a struggle. No, like not a struggle, but something I have to work towards that maybe I should have done more in my PGY like 2 and 3 year. I did a little bit of it, but I think now like as much networking as you can do is important because that's the best way you're gonna kind of figure out about jobs and have maybe an inside track and um a job that's very desirable because it unfortunately really does matter who you know. It's not just, how much work you put in day to day at the hospital that you're training at when you're, going to be considered for a position.
Your program should also advocate for you too. Like our program sends out when they know that they're good practices hiring. They encourage the fellows to apply or the people below. So it's nice that they kind of keep that at the forefront. And then also there's usually a network. So we're not the first people to graduate from the residencies that we're in. And so fortunately, the program directors usually know where everyone else is. So if there's a geographic area that you're interested that's not, so like I don't know where I want to stay, but it might not be New York. There's people from Sinai everywhere that they can kind of connect us to. I'm sure it's the same for UCLA, the same for University of Michigan, same for Jefferson. We're not huge programs, but there are quite a few of us every year. So that's something to connect with. Our fellows, with the exception of one, are all doing 100% IR next year. The one that's not is doing 80/20. So it's definitely out there. We have 5 fellows. And some of them said they compromised a little bit on like location to get that job, but otherwise they felt like the hours and pay were they were very happy with it. So I'm sure you guys have heard people compromise on something for job location, pay, or call. So that's all I got though. I'm a 3. I'm thinking about that in an abstract sense.
I think I'm also like Sagar, like putting the feelers out there, trying to find some good jobs. And one thing that I have started to do when I'm looking at practice descriptions is to pay attention to does this group have like an OBL? To me, that's an indicator that they have some semblance of like a, hey, we want to advocate for like a clinical practice model. Um, do they talk about having a clinic in their description? Do they talk about they throw buzzwords out there like full spectrum IR, you like clinical IR, pay attention to these things because um, you can also go on their websites and if it's like we offer such procedures as angioplasty and they like keep it real generic, I'm like, well, okay, yeah, I hope so. Like, what are you actually doing? Um, it can be really tough to parse out. Um, when it comes to like the bulk of what's out there, um, I think it's important to consider sort of the way the market is right now, which is in the year of our Lord 2020, we had the Great Plague, which severely uh, seriously disrupted the radiology job market by forcing all of DR to be like from home. So everybody got home workstations and everybody was like, ooh, this is cozy. I don't have to, flip people off in traffic on my way to work. I kind of like this. So now to keep these nice hospital contracts that all these like private practice groups had established, IR is like the link to the hospital in many ways. But that kind of means that you end up in some ways, like for the practices where IR is a part of the DR group, um, you're kind of they like you because they need you there, but they don't really like care about what you're doing as long as it's bringing in RVUs. You're like an RVU creator for them in many practices. I'm not trying to paint with too broad a brush here. This isn't like every group out there, but this is something to like pay attention to when you're looking around for different jobs. Um, and I guess I would say to add to that is know your value because you are the link to the hospital. I think a group that knows its value is able to advocate for a more clinical practice and um, advocate for a less RVU based kind of churn and burn mentality. I think that goes a long way because the reality is IR and people who are willing to be at the hospital are like the thing that stands between um, like market forces and radiology becoming subsumed by hungry private equity based telerads groups taking over all these little contracts. So um, anyway, know your value and look for a job that is full spectrum, etc.
Thank you all. These are great points that I don't think a lot of students, I certainly have not thought about these, but it is important to just sort of keep a realistic mindset, that there can be some challenges going into it. I just want to do a small plug for Outpatient Endovascular Interventional Society. Nate, when you mentioned OBLs, that sort of reminded me of it, but it's a great like place for us to learn about like different practice models and, the potential that VIR does have to offer in sort of the private practice, independent practice world. Um, Nobody has a crystal ball, but in your opinion, maybe what you've seen, what you've heard, how do you foresee the field of VIR changing over the next 5 to 10 years? And do you feel like you're prepared for that change if it's changing at all?
I think about this a lot. Um, I think it's because I got like an MBA with my MD, and I think a lot about like how do I want to practice and what kind of freedom do I want to have to practice the way I want, and what kind of sacrifices do you have to make to kind of get there. Um, if I had to imagine like at least the way reimbursements are changing, outpatient work tends to be reimbursed at a higher rate than inpatient work, and it's been that way a long time. And they're pushing people more towards these outpatient procedures, but at the same time seem to be cracking down on like ambulatory surgery type procedures. So I kind of see the billing going towards more like an outpatient hospital admission where you go to like a big institution and get your procedure and go home the same day versus an OBL. Um, but no one knows. It depends on like the lobbying. So 3 years ago, the reimbursement rates for certain procedures were very different. And they recently announced last month that they changed the coding for like angioplasty and PAD work, that instead of having 12 codes, it's being expanded to 48 codes. So no one really knows. Um, but I don't think the hospital is going to, like the hospital system and the medical system is going to encourage people to stay in the hospital any longer. So I do think like IR is uniquely positioned compared with other specialties, because we can reduce hospital length of stay by doing things that are incredibly minimally invasive. Like for example, I don't know if you guys saw, instead of liver resection for solitary colorectal metastases, there's a big paper that came out in Lancet talking about ablation. If you get a liver resection, that's generally not like an outpatient procedure, versus ablation, as I'm sure people have seen, same day in and out. So I think IR's in an incredible position, but the question is going to be, are you going to be your own boss in an OBL? Are you going to be in a major department that's its own IR department? Are you going to still be with the DR group? People don't know. But at least the model we're working under, we're actually a part of our DR group underneath it. But our department has a lot of freedom because they do the complex work that generates enough revenue that lets them have that seat at the table. I don't know if that answered your question. Did that answer your question?
Totally. It did. Thank you.
Think there's some IR attendings at in my hospital who I kind of like keep like they don't get too pigeonholed and comfortable within the academic world. So like they've taken billing courses and they kind of, instead of just going by the SIR template, they'll kind of teach us also, and they'll do it themselves, kind of dictate the way that they know is gonna reimburse the maximum amount, even though that's not something that all the attendings do or the kind of department really requires. They take it upon themselves to kind of stay on top of that. Also in terms of like incorporating cost, like in an academic big institution, like you can kind of open whatever, use whatever, and then not really care about it. But some of them really make it a point to try and stay kind of with like the money in mind, in case everything starts moving to a more OBL setting, where that's kind of a metric that's like taken with more importance. So just stuff like that I think is important. So I think if I end up at an academic institution, I definitely will kind of pursue taking a billing course and kind of keeping in mind that the cost of certain balloons, wires, catheters, or equipment, and what can be done kind of at the cheapest amount, not the cheapest, but keep the cost in mind to try and in case everything shifts in the future, you're not caught blindsided.
All right, and I do want to leave time for an audience Q&A, but I'm just gonna, give everyone on the panel here an opportunity to give any final advice they have for applicants who want to pursue 100% clinical VIR career. It could be short or, long advice, whatever you can pull off the top of your head.
And a short one, paying attention to not just the fellow autonomy, because it's a good way to see, okay, this institution is doing this kind of procedure. They're following their patients. They're doing these things, but the attendings are doing that. How much of this is translating to what the actual trainees are getting? And then like a good kind of benchmark for that is, okay, your first year graduates, as soon as they're junior attendings, how comfortable are they then leading that on their own? How comfortable are they stepping into that attending role and how, running a service, running their own practice? I think paying attention to that and what kind of role they're in and how comfortable they're in that role, because it's growing pains for everybody when they get out of training, but it's a good way to kind of see, okay, generally coming out of this institution, how prepared is your average graduate to practice? I think is just a nice thing to pay attention to.
would encourage you to I know we're thinking about like the long term and like where our residencies getting us to. But when you're looking at residencies, look at the people that are there, how supportive their culture is, and kind of what support means to them. Um, Things can change in 6 years. I don't think I intended. I know intended to have a baby, but I didn't like really think that through of like what that would look like with residency and like, right? He's here. And I've been able to do good things to support my co-residents taking different shifts, and they've done amazing things to support me. And also having like a program director that's an advocate for you. And again, you won't, I know that sounds really generic, right? So like how do you ask that as a med student? Ask them things of like, what ways have your program director supported you? Like, can you think of a time that they really stepped up for you, or just ask them that on your interview. I think they might be surprised when you ask that question, but it could really tell you a lot about the program itself. Because it does matter. Most places will make you confident, but you also want to like leave and kind of feel pretty much happy about the job that you're in. I think most of us are. That's why we're on this panel. But those are things I didn't necessarily think of that I just feel very fortunate that my program is incredibly supportive and I have really wonderful co-residents that we're willing to kind of work together to make everyone, I don't know, have the best life we can while we're in residency.
I totally agree with that. And I think it comes for me when I was like trying to figure things out, um, I made this like insane like calculation based spreadsheet and like all the programs I ranked. There was some sort of like it was just ridiculous. I made like 8 different iterations of my rank list, and in the end, I just like went with my gut and like which place did I like best, and I should have just did that from the start. So pay attention to your gut when you're out there looking at programs. Pay attention to the vibes. Get a solid vibe check. It's tough out there in this post-COVID Zoom world to really like understand how a place is. So if a place has like a non-creepy second look thing where it's like after they've made their rank list before you've made yours, um, think about doing it just to get a vibe check if it's somewhere that you're really, really interested in.
Yeah, I guess I was kind of spoiled because I had all in-person interviews, probably same as Nate back then, and it was easier to suss out the vibes. But yeah, I think like Lindsay was saying, the questions like what would you change in your program, or what are recent changes that have been done in this program, and kind of learning, like kind of gleaning from that, is really important. And I mean, I'm assuming everyone can kind of figure out where they want to go after the interview. So, like just work on, like, I think everyone kind of knows what they have to do to improve their application. Even if you kind of hate networking, you kind of hate research, just do it, do it to get into the program you want to get into. And kind of stay like really well versed as you can, because you'll probably make a rank list of places you want to go, but then do you still want them to, want you. So work as hard as you can for the next year and a half, and put everything out on the table, so then after match day you can kind of have no regrets, or kind of have no, oh, I should have done this differently.
Thank you all for those great pieces of advice. So I want to open it up to the audience here for the last few minutes of this session. We have 4 amazing VIR residents here. You can pick their brains. Feel free to use the Q&A feature. If you can't figure out how to use that, you could drop your question in the chat. You could unmute yourself, whatever you're more comfortable with.
Hi, I had a quick question. Thank you all for doing this panel. It's been super informative. What are the best ways as you've grown throughout residency you feel to keep up to date with new trials coming out, new forms of evidence-based medicine where you say, oh, okay, we've been doing a certain treatment this way, now we should transition to doing something else. What are the best ways to do that? How often do you check those sources to stay up to date?
I have a pretty long commute, unfortunately, so I listen to Backtable on my way in whenever I can. And then I think tumor boards help a lot. Just different tumor boards, different subspecialties, kind of logging in with our attending. learn a lot about the kind of new trials that way. Because you have oncology there, radonc there, hepatology, nephrology, pulmonology, whatever the tumor board might be. And if there's any big changes to the practice paradigm, you're going to hear about it there. And if it's different studies coming out from different like Radonc sometimes pull out these like 5 patient retrospective reviews to try and say that they should do something, and then you look into the trial and you see, this is kind of not the way to go. But just logging in and paying attention to what each subspecialty says and kind of looking up what they're alluding to in terms of what trial came out. I feel like those two things have been helpful.
I feel fortunate we have a journal club that we try to pair with our didactics. So at least once a week we're talking about something. And then because you have that DR time, right? Like I'm still kind of in the beginning of my residency, so 4 months a year is a lot, but not that much. Doximity I have set up for alerts and anything related to like IR oncology PAD comes in, which is how I found out about that Lancet trial for colorectal cancer metastases to the liver. Um, and then also it's like kind of dorky, but like signing up to do like reviews if your attendings like are looking for somebody to write a quick review. Like no one wants to sign up for another research paper, but it really helps you like understand what literature's out there because you are creating literature. So work be getting more work. But it really has helped me learn so much creating that kind of stuff.
Yeah, that is true. I think especially like if you're in some sort of academic world, these people, your attendings are like usually being approached by various people to be like, hey, could you write this paper on this? And they're then going to approach you and be like, hey, what about writing this paper on this? So anyway, the work kind of trickles downstream. Um, so there's lots of opportunity that way. But I also my residency has like a fellow run journal club, which I think is really cool. So we do this like every Wednesday morning, like right after rounds, brief like 30-minute discussion of some article. So that's one nice way to kind of like keep people abreast of what's going on. And what else? Yeah, I also like Sagar. I'm kind of a back table junkie. I think it's really like an easy kind of passive way to like expose yourself to like what are they doing in this, weird niche pathology? Like, do we do? I don't know. I can't come up with something off the top of my head. But anyway, it's a great resource. Strong recommendation.
Also going to conferences, great to network, great to meet people, but also there's, the people who wrote the guidelines are often on the podium speaking, and then you can come pick their brain after. The amount of times you've just been in like the exhibition hall talking to somebody who's run a giant randomized control trial and their thoughts about the current state of where our data is and where things are moving. All of that's just really valuable. We also have journal clubs and stuff like that too, but just an additional plug for conferences.
My wife's a primary care doc. She has this podcast. I'm gonna figure out the name right now and put it in the chat. That's really good to listen to too. It's called Curbside or something. I'll figure it out. But yeah, it's nice because they go over, even basic disease processes. The further you get away from kind of med school and intern year, the more you kind of forget about that stuff. And sure, it might not come up on a day-to-day basis, but if you're on the phone with like a medicine team or something and you're just way off the ball in terms of what you think like is going on with someone's heart disease or kidney disease, it could look really bad. And it's just, bad practice. So I listen to that too, because I think podcasts are a good way to learn.
I love that. Like Stat Pearls and American Academy of Family Physicians has like amazing review articles for basic stuff for clinic. So if you're like brand new and you're like, I have no idea what this is, those are good places to start and make you look a little bit smarter than you would have otherwise.
Yeah, it's called Curbsiders Internal Medicine. So if you're ever bored of back table, I don't know, give it a try.
Yeah, that was a great question, Tiffany, because it really highlights these things are like the backbone, the RCTs, the foundational, knowledge on disease processes is a background for how we practice. So very important. I have a question here in the Q&A. How involved are you with triaging scheduling? I was surprised on my first rotation how time consuming it was to decide who goes where.
The Tetris, Tetris thing, the snapboard is like a skill that takes a long time to develop and something that you're going to spend a lot of mental energy on. So, um, you know, I don't know. It's not something we talk about very often, but it's actually like a big part of the consult role is like deciding like who is sick enough to like warrant bumping these other people. And if somebody has like something that can be pushed off to a more optimal time, like how best to do that, what's the best use of anesthesia resources, like basically you're going to be like distributing a very, very finite set of resources. Um, and it just takes time and doing it to like get good at.
He means you're going to make mistakes when you do it, and it's the resident's problem. And most of us, it's our problem when we're on the consult rotation. That's what's like in my thing, and I've seen other programs do the same. Jonas, Sagar, is it the consult person that has to deal with all those problems, or is it someone else?
It depends what kind of day it is. So like that weekend consult thing, yes, it's on you, and there will be teams that really want you to do something that you don't really have to do. And there's been situations where there's a trauma patient and they're getting their scan and you're holding off on doing something that could be done later. And you're glad you did because that patient needed to come for an angioembo. And so things like that, where it's really easy to just say yes to something right in front of you that it is indicated, but maybe not indicated right now. And that's something that we do get pretty like that happens every time you're on those consult weekends as a junior. In the inpatient, like at our main hospital, when you're actually on service, I would say intern year, I really wasn't asked to do any of that when I was on. This year, only towards the end of this year, has that come up where they're starting to, pull me aside to maybe help shuffle the board around or move things, but it's still just in bits and pieces.
We have a procedure, President Rowe, who in the morning, like when we run the board at 7, we'll kind of have everything organized with the like lead nurse and our attending. And then we've always like said we do this, but we didn't until we had a new chair a couple months ago. Is an afternoon running the board. So around like 1 or 2 o'clock, we'll like get together again, and hopefully it's the procedure residents, whoever there's the next most senior, and the attending and the lead nurse kind of triage, who can be pushed and who cannot. And you make mistakes and you learn and you figure out, which team is turning over which room or which attending is going to do which case, which kind of unfortunately plays a role into how fast we can, get through cases. And it's trial and error, and it is an art form that takes many years to kind of, I think, get right. And even then, you'll probably still mess something up.
You also learn politics that way. I knew nothing of hospital politics before this, but when you're dealing with like every team in the hospital, you quickly learn like how that works. And that is, you can decide to think of it as infuriating or as a learning opportunity for your practice in the future. So all good experiences. And it's nice, depending on your program, I feel like many programs give residents a lot of autonomy in making some of those decisions. And that's where you really grow, right? Like having to actually come up with that plan yourself and see if that's going to work the best.
Thank you all so much. We're at the end of the hour and we want to respect your time. Thank you for coming on and doing this. I learned a lot, and I'm sure everybody here learned a lot from your valuable insights. And we know you're busy, so we definitely appreciate you taking your Sunday afternoon to come and speak with us.